Hello and welcome back. I'm Dr. Egdan Rashad and you are listening to the Psychopharmacology Institute podcast. Our goal is to help you keep up with the latest in psych and become a better prescriber. Before we get started, why don't you go to piupdates.com to sign up on our website, earn CMEs, and receive regular psychopharm nuggets of joy. PI stands for Psychopharmacology Institute, by the way. So go for it. In the last episode, if you remember, I posed a clinical case. Let's revisit it. You have a 45-year-old patient with treatment-resistant depression, who you've been treating for some years now. He has recently read about how intranasal esketamine was FDA approved earlier this year, and he would like to try it. My question was, what would you be most concerned about with esketamine? Thanks for those wonderful clinicians who got in touch with a response. Some of you said you'd be concerned about the cost, psychosis, sedation, and other adverse effects, which are indeed valid points. Throughout this episode, we will be uncovering some of those concerns, as well as talking about the indications and clinical caveats associated with using esketamine. So it all starts with ketamine being used as an anesthetic. To be more specific, a dissociative anesthetic. Dr. Sam Wilkinson from Yale School of Medicine elaborates.
This name refers at least two concepts. One is that subjects may be disconnect from their environment, but it also may refer to the fact that sensory inputs are reaching cortical areas but are not always perceived in association areas.
Ketamine and esketamine are like non-identical twins. In more sophisticated terms, esketamine is the S enantiomer of ketamine. Let's talk a little bit about the mechanism of action.
So the initial idea was that ketamine is a known NMDA receptor antagonist, and there's a high density of NMDA receptors in prefrontal cortex, in pyramidal cells, in hippocampus, and that if you block the NMDA receptor, it could translate to increased glutamate outflow in particular brain regions that are involved in mood, let's say. So the initial idea was, well, if we know that that's one of the mechanisms of how ketamine works, then the class effect that people looked for but were really not finding over the last 10 or so years has been to look at other NMDA receptor antagonists, from riluzole to memantine to rapastanol to some of the other drugs we were talking about today, most of which have failed to demonstrate an antidepressant effect. And so that led to more questions about, well, why is that? What's unique about ketamine? Because ketamine seems to have a fairly large effect, very large effect, with a very small number needed to treat. And yet you can't just say, okay, let's just pick a different NMDA receptor antagonist and hope to see the same thing.
That was Dr. Joseph Goldberg, clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai. I interviewed him at the 2019 ASCP annual meeting in Scottsdale, Arizona. So Dr. Goldberg mentioned that ketamine works as an NMDA receptor antagonist, but other drugs do this too. Why is ketamine special? Could it have some tricks up its sleeve?
Ketamine's got a good dozen receptor targets that range from known mu-opioid receptor binding to sigma receptor binding to serotonin reuptake inhibition, norepinephrine, alpha-7 nicotinic receptors, muscarinic receptors. I refer to it as sort of an old-fashioned dirty drug. So we know that there are many mechanisms that the drug does. I think the questions come down to matching up putative mechanisms with clinical observations. Ketamine does more than treat depression. Ketamine is a preoperative anesthetic. Ketamine is an anti-nociceptive drug. It's used in regional pain management. It's a hallucinogen and so on. So at different doses, different effects are seen. And we don't know if we can fully say, well, the anesthetic effects come from an NMDA receptor blockade, but maybe the depression effects come from elsewhere.
So that's what makes ketamine special. It acts on an array of other receptors, and different doses have different effects. You should note, though, that esketamine has not been shown to act on the sigma receptors, which basically modulate the opioid system. So we have touched upon the mechanism of action of ketamine and esketamine. Let's snap back to reality, clinical practice. Intranasal esketamine, or Spravato, is now FDA approved for treatment-resistant depression. in conjunction with oral antidepressants. Ketamine can be used off-label for TRD in IV infusion form. When I asked Dr. Wilkinson about the efficacy of ketamine, he replied with the following.
Ketamine has emerged as the prototypical rapid-acting antidepressant. Early efficacy studies showed a high rate of response in the range of 64 to 71% to a single dose of ketamine among individuals with treatment-resistant depression. Later clinical reports of the effectiveness of ketamine in clinical samples have demonstrated generally a lower response rate in the range of 50%. Now, this discrepancy between efficacy and effectiveness is not entirely unexpected and can frequently be seen as new treatments are taken from clinical trials to real-world settings.
Fair enough. It is exciting, but there's still more room to identify just how effective it is. So what should we, as clinicians, be concerned about? Well, let's talk about esketamine here. Patients need their blood pressure monitored since it can cause hypertension. Also, due to possible nausea and vomiting after administration, it's advised not to eat for at least 2 hours and not to drink for half an hour before taking Spravato. Furthermore, since it's technically a dissociative anesthetic, there is a clear risk of, dissociation and sedation.
Another important question is whether repeated use of ketamine can induce long-lasting cognitive or perceptual changes or psychotic symptoms. A number of studies conducted by Celia Morgan and colleagues have found changes in cognitive abilities and schizophrenia-like symptoms among frequent ketamine recreational users. Compared to other groups, such as ex-ketamine users and non-ketamine polydrug users, frequent ketamine users have showed impairments in spatial working memory as well as pattern recognition tasks. Notably, frequent ketamine users also scored higher on measures of dissociative and delusional symptoms compared to other groups, including ex-ketamine users and non-ketamine polydrug users. The unanswered question then seems to be how much ketamine is too much. There are legitimate concerns of the long-term effects of ketamine on cognition and abuse. However, there have been no systematic reports of iatrogenic addiction or persisting psychosis thus far from the studies that examine the therapeutic effect of ketamine in mood disorders.
So in summary, there are still unaddressed concerns about the long-term use of ketamine in terms of abuse potential, long-lasting cognitive and perceptual symptoms. So here's the thing. Ketamine and esketamine have opened many new doors. They bring us closer to having a rapidly acting antidepressant/anti-suicidal agents, but they also raise concerns for their long-term safety.
The possibility of rebound suicidal ideation remains that could occur within a few weeks or months of a patient receiving ketamine for suicidal ideation. How much follow-up should be put in place for these patients who abort or have a shortened hospitalization as a result of their exposure to ketamine? In addition, no study so far has demonstrated that ketamine can reduce the risk of suicidal behavior, only of suicidal ideation. And it's important to point out that suicidal ideation is not a very specific indicator or predictor of suicidal behavior.
That's an interesting little nugget of information. And there's still a lot to talk about in terms of ketamine and esketamine. I just hope to cover the basics of it today, and further down the road, we will venture further into some specifics on how to prescribe them. And that's about it for today. Now, here come the key points. Ketamine and esketamine are known as dissociative anesthetics that act as NMDA antagonists as well as on many other receptor sites. Ketamine has emerged as a prototypic rapid antidepressant, and it is also found to be useful for treatment-resistant depression. There are long-term concerns associated with ketamine use, including abuse potential, increased risk of psychosis, and also cognitive deterioration. Did you know that a lot of today's content was extracted from our CME presentation entitled Ketamine in Clinical Practice? Well, check it out on our website. Visit paiupdates.com and become a premium member already. We have a bunch of CMEs for you to collect. If you are a psychiatrist in the US, we also offer SA credits. You could also go onto our website and join our newsletter to receive weekly updates delivered straight to your inbox. The following people participated in this episode: Dr. Flavia Guzman as a general editor, Andy Rode as audio engineer, Pamela Gonzalez as the project manager, and myself, Dr. Wegdan Rashad, as the host. We'd also like to thank Dr. Sam Wilkinson and Dr. Joseph Goldberg for being with us. Thank you for joining us in today's podcast. Until the next episode, goodbye.